Well, I'm Dr. Robert Litchfield, and we're here at the Schulich School of Medicine at the University of Western Ontario, which is in London, Ontario. I work as an orthopedic surgeon out of the Fowler Kennedy Sport Medicine Clinic, and the research that we're discussing is taking place in our clinic and also with the Robarts Clinical Trials Group, which is a clinical trials research group here at Western. This trial is a single-centered, blinded, randomized clinical trial involving patients with osteoarthritis of the knee of moderate to severe grades, primary arthritis of the knee, and these patients were randomized into two groups. The initial group, or the control group, was the conservative treatment group, which involved physiotherapy and medical management, and the second group had an arthroscopy of the knee followed by best medical management as well. So it was a 2-year study following approximately 180 patients with these two different interventions. The outcome was that the surgical group at 3 months was improved over and above what the non-operative group was, but beyond 3 months we found no differences whatsoever right through to 2 years on any of the outcome measurements that we made, including patient-derived outcomes as well as a number of different satisfaction outcomes as well. Like the Moseley study, the tool that we used as our primary outcome was the WOMAC, which is the Western Ontario McMaster Arthritis Index, which is a validated outcome tool for knee and hip arthritis and really is the most widely used tool for this purpose. The Moseley study did not use a validated outcome tool like the WOMAC. Well, the procedures that we looked at were arthroscopy, so using a standard arthroscope and using instruments such as shavers and mechanical biting instruments to remove loose fragments of cartilage, smooth off damaged areas of meniscus, irrigate out the joint of any loose pieces. So these are very common arthroscopic instruments and are certainly not unique to knee arthritis. They present really primary symptom is pain. They all present for surgical referral for consideration of various treatments, but they have pain as a primary feature. Other features that we looked at were mechanical symptoms, locking, catching, swelling, and then their disability with their activities of daily living and their activities of choice. Arthroscopy has a huge role. In the knee as itself, we perform all kinds of reconstructive procedures that the arthroscope has made enormously easier and I think better for the patient, and that will include ligament reconstructions, cartilage repairs and transplantation of cartilage. There's all kinds of new technologies that are showing promise of how to fill in cartilage defects before they really get to the arthritic stage. These are all procedures that are I think very useful, and the arthroscope has made a huge difference and benefit to society. We wanted to emphasize out of this trial that some of the upsides is that the non-operative treatments work. So people were getting better with the combination of education and exercise and all the other modalities that have been shown to work. And as surgeons, we tend to jump towards operations pretty quickly. We need to remember that arthritis can certainly be treated with a number of non-operative modalities quite effectively.